really by saying that post-COVID is a new phenomenon, but it is not something that is completely new to medicine. In the 1892 Russian influenza that killed about 1 million people globally, it was widely recognized that survivors of this disease could have persistent neurologic disorders, psychiatric disorders, or lingering effects, even among survivors. And the father of modern medicine, Sir William Osler, said almost every form of disease of the nervous system may follow influenza. And this was very well documented in their time, that people could have psychoses, encephalitis lethargica, severe post-viral symptoms that were recognized on a wide scale, affecting a whole generation. And so, as we'll talk about, there may be something unique about COVID and the way it is a diffuse multi-system disease. But it's probably just that we've never seen an infection on this scale in modern times that is making us recognize that this is a post-viral illness. So I'll start by a little bit of what is post-COVID, long COVID. Well, the hard part is nobody can seem to agree what the actual name of this is. The NIH wants us to call it post-acute sequelae of COVID-19, which is PASC. Otherwise, in the British literature, which is defining a lot of our knowledge of COVID-19, they call it long COVID. The CDC decides to call it post-COVID syndrome. Patients themselves are calling themselves COVID long haulers. I tried to call our clinic the Longhorn Long Haulers Clinic, but apparently the football team did not like that trademark infringement. And anyways, at this point, unfortunately, as we'll talk about, there's no consensus or diagnostic criteria. So it's kind of reported all over in the literature exactly what this is. But I think the best definition comes out of Britain. They define that the initial COVID illness can last up until 4 weeks. You can have ongoing symptoms and not be fully recovered from 4 to 12 weeks. But really, PASC or long COVID is more than 12 weeks from symptom onset, is the basic timing. So let's talk a little bit about the acute COVID illness first, and then we can kind of get into what the recovery phase looks like. And I start all of this by saying my disclaimer. A very smart professor of medicine told me in medical school that 50% of what you're taught in medical school is either wrong or negligently incomplete. The problem is we just don't know which half that is. And so this is very much subject to change and a work in progress. And I'm sure 50% will be different in another couple months. So looking at COVID in general, the first part of the disease from symptom onset is a viral phase that is indistinguishable from another cold or influenza-like illness that has some more predominant neurologic effects, dizziness, orthostasis. A little bit later in the disease course is the pulmonary phase, where it starts to affect the lungs. That's really what brings people to the hospital and defines severe disease, and is really defined by inflammation and the host inflammatory response. The third stage is the thromboinflammatory phase. Really, people have small clots throughout the full body, leading to end organ failure. This is when patients require ventilation and have critical disease. And this kind of fits on a time frame. Most people recover within the first 7 to 14 days and don't require hospital admission. But interestingly, if they get this severe lung disease, ARDS, requiring intubation or mechanical ventilation, that's almost entirely independent of viral replication, that it is almost completely due to the host, a dysregulated host immune response. Some people call that a cytokine storm, but it's really from diffuse microthrombi throughout the body of small vessel damage that is a multi-system disease. And our treatments are really targeted towards that, either preventing viral replication early in the disease or tamping down the immune system when patients get sicker or in the hospital, targeted to each of those phases. And so this is kind of the $1 trillion question right here. 40% of people are asymptomatic from COVID, maybe even up to 50%. About 90% of cases are mild to moderate, not meaning they don't feel sick, but they don't require hospitalization or further treatment in the hospital. Only about 10% of people will have severe symptoms or pneumonia that requires them to be in the hospital. And 5% of patients who get COVID will get critical symptoms. And so it's interesting, why do 40% of people, their immune system just handles this fine, and then 5% have critical disease in the hospital, leading to this cytokine storm and dysregulated post-immune response? And now taking this into post-COVID disease course, what if the end result isn't hospitalization or death, it is recovery? What does that start to look like? And we're seeing a couple different things. If people were in the hospital having severe or critical disease leading to lung damage, we're seeing that they can end up having lung scarring, pulmonary fibrosis, that the kidney damage can be permanent. They can have weakness and post-ICU syndrome, which also consists of PTSD, anxiety, depression, or heart damage. And we know from the literature that these patients can be extremely sick. In one study out of Michigan, the readmission rate to the hospital was almost 15%. Almost another 7% of people died even after they left the hospital. And the disability from people who were hospitalized is really terrible. Almost 40% of people were unable to return to work or had severe financial difficulties following their illness. This is lingering with people. Similarly, from China, a very large cohort of patients, over 1,700 discharged from the hospital. At 6 months, 3/4 still had lingering symptoms. A lot of this was fatigue and muscle weakness, sleep difficulties, but interestingly, we saw a lot of psychiatric disorders, which were new. And based on the severity in the hospital, if they just needed a little bit of oxygen, about 1/3 had lung damage. But if they were on the ventilator, almost 2/3 of those patients had lung scarring. But what's more interesting, and I think what we see a lot of on the news, is what happens to these people who just had kind of a mild illness. They felt sick, but they never need to go to the hospital. And then all of a sudden they're developing new symptoms, really characterized by fatigue or post-exertional malaise, which is a fancy way of saying a small amount of, a small task that should not be that disabling really leads to severe fatigue and wipes people out for days. But then we're also seeing some interesting things like dysautonomia, problems of the nervous system, and the neurologic conditions like brain fog and cognitive dysfunction. And so a systemic review in JAMA really showed that, it's not perfect. We don't have definitions of what long COVID is, and every study is using a different time point, but they're saying high rates in the literature of persistent symptoms, really difficulties breathing, fatigue, depression, neurocognitive dysfunction being the most common. And so what I'm going to propose of, why do some people have this strange inflammatory response leading to these diffuse symptoms? And I think it's important that we start thinking about post-COVID not as a forest, which the literature kind of describes it all as one thing, but let's talk about the different trees involved. And I start to see in our clinic that there's 3 different phenotypes or clinical presentations or flavors of patients who come in. The first being end organ damage, that these patients were severely sick in the hospital and that their lungs, kidneys, or other part of their bodies, they had strokes or heart attacks, and they've just got the scarring. There's another group of people who are just taking a long time to get better. This is common in other, even bacterial pneumonias or other hospitalizations, that it can take 6 months for people to regain their capacity to do daily activities. And it's just taking a long time for them to get better. And I think the interesting one, and Dr. Melamed is going to talk a lot about what are the people who this virus just seems to trigger a dysregulated immune response, that they're, the body can't distinguish between fighting the right things or fighting itself. They have chronic inflammation and neurologic problems that were not present before the disease. And that's really happening in young people, usually women 30s to 50s, which is common for other autoimmune disorders. And I will say, I break them into 3 categories, but it's not perfectly sent together. I think there's a full spectrum of people can have a little bit of all of these things, and probably some underlying pathophysiology, although each group does present a little bit differently. And so what's interesting here is this is another study that asked patients themselves. This was a patient-reported outcomes. And you can see that the fatigue and post-exertional malaise, brain fog were the most common symptoms and quite common. But interestingly, within those phenotypes, if they broke them apart by who had the post-exertional malaise, that they exerted themselves and were laid up in bed for days, that they each had a little bit different clinical course, that people with more of this autoimmune had more post-exertional malaise, that people who started to get better from the post-exertional malaise really had a quick recovery after about 6 months. And then this group that just persisted through without, who did not have any of the PEM. And so what's interesting about this disease is almost like HIV or after September 11th, there is a large and very well organized support group and advocacy group that are really engaging with researchers, engaging with each other online. We've been able to give a webinar to a local support group here in Austin that's on Facebook. And the big one is probably Survivor Corps. These patients are just eager to participate in research, advocate, and support each other. And if anybody's interested in further reading, there's a great article in the New Yorker that just came out, a little bit about the struggle of defining COVID and that interaction between patient advocates, patients, and the researchers who are trying to really meet the scale. I think in general, we said 75% of people can have symptoms depending on the literature, but most of it's really settling around 10 to 30% of patients who get COVID will have persistent symptoms. But if you take almost 4 million patients in Texas, which is probably a lowball estimate of having COVID, we're looking based on that math that there's probably 500,000 people out there who have had COVID and are still not better, just in Texas. And think about expanding that globally. And so Dr. Melamed is going to talk a lot about this, but I think, with those phenotypes, COVID-19 really is a multi-system disease. We have a lot of proposed pathology, pathophysiology for each of these phenotypes, whether that's just damage from the virus, low oxygen, blood clots, whether it's autoimmunity, or whether it's chronic inflammation, probably a mix of all these things with people. But we used to think of COVID at first really being a disease of the lung, but we know absolutely for sure now it's truly a disease of the small blood vessels throughout the body. And it just happens, in the severe cases to affect the lungs primarily, and that's what's killing people. So what are the risk factors for developing PASC, or the post-acute sequelae of COVID-19? This isn't great literature. The first one is the sicker you are and the more symptoms you have at your initial illness, the more likely are you to develop persistent symptoms. Similar to having severe disease, obesity and BMI are heavily associated. Interestingly, men get sicker than women in the initial illness, and more men are dying than women, but women seem to have lingering effects and not recovering as soon. Also, people who have higher rates of virus in their body in the initial illness also increase the risk. The question I always get of, now that people are fully vaccinated, what is the risks of developing breakthrough infection? And I think we don't know the answer to that. Fortunately, once again, the reporting usually just says any symptom, and any symptom does not mean that they're not getting better or they have the severe neurologic consequences. I think the vaccines in most studies have demonstrated to absolutely reduce the risk of all of these things listed, but the risk of developing long COVID is not zero. It's much less with the vaccine, but there are reports. It is not completely eliminated, unfortunately. So in the clinic, how do I approach these patients? Let's talk about that for a second. I think first of all, my beginning approach is I just believe the patients. Unfortunately, in the medical community, we have a tendency when things are unknown, unexplained, we tend to dismiss them or try to convince the patients that it may all be in their head. It's very strange. I've had about 5 patients tell me that they just feel like their whole body is shaking or vibrating. And it's not, they're not having seizures, there's not clear, but all 5 of them are not making this up together. It's not a conspiracy. That just happens to be a symptom of likely the neurologic manifestations that we don't have a good explanation for or a therapeutic target, but we just have to take their word for it. And I think that's especially important for women and people of color who this disease is disproportionately affecting. And we have a problem in the medical community of dismissing their complaints. And we got to do better than that. Next, I really think about evaluating for other causes of symptoms. In a young 25-year-old who's previously healthy, this is usually pretty easy. But when you get someone who is 70, may have diabetes, is at risk for cancer, I do try to think of other causes that could talk about their symptoms. And with that, I do a focused workup, ordering testing in labs for looking for that other disease states that may have been triggered by the virus or damage to the body. I kind of liken post-COVID to this though, because most of the labs and workup come back normal, especially if they were young and healthy. That the existing tests we have in clinic are almost like fire alarms, and that the disease itself, especially for the dysregulated immune response, is more a problem with the kitchen wiring that is just sparking. And our tests will only catch the problems if the patient's on fire, which is usually good news. Doctor kind of takes us to number 1 of doctors are usually saying, well, our tests are normal, you're not on fire. But that's really no consolation to patients who feel like their body is fully short-circuiting all the time. The next part, we in clinic screen for mental health comorbidities and health-related social needs. I just assume everybody who comes into clinic is depressed after 2020, especially if they're into 2021 and they're not recovered from COVID. And we know that the financial consequences of people losing their jobs, being laid off, compiled by them not getting better, are just terrible. And the feeling of losing that ability to care for oneself or family is really devastating. And so we have a social worker who really tries to evaluate them and help them. We think that everybody will get better a little bit with time, but breaking that cycle of being out of shape and not being able to do things by a supervised and graduated exercise plan. Once again, and we'll talk about, we don't tell these patients to push through because that post-exertional malaise is absolutely real and can be debilitating, but slowly building up the tolerance over time with exercise helps all the physical, mental, and cognitive problems. And plus 2, we know for a lot of people that they will get better with time. And in post-viral illnesses, that can be a year. Other diseases we've seen that can be 2 to 5 years. And so people are slowly getting better. Some likely with autoimmunity will need some extra help, but we provide a lot of reassurance that what they're going through is real and will get better if they stick with it and give it time. So I'm going to go through this briefly, but for shortness of breath in clinic, that's a very common one. We're actually finding that most people do not have underlying lung damage, and we get that by getting lung pulmonary function tests and other baseline labs to make sure they're not anemic. And really, if that is abnormal, we're looking for lung scarring through CT scans. But that's usually uncommon. Usually the shortness of breath is a mixture of their dysautonomia, which we'll talk about, fatigue, and a constellation of other symptoms. Or, our testing is just not sense enough to see that small lung damage. The fatigue and PASC can be absolutely debilitating. It's absolutely real. We recommend everybody do physical therapy so they can be monitored, they can have a graduated exercise plan, and they don't push through because, as I said, that post-exertional malaise is real. And a lot of what we do is counsel on energy management strategies. Interestingly, the neurocognitive dysfunction is clearly linked to the level of fatigue. The more fatigued they are, the worse their memory is. And it gets worse. It's pulling from the same battery that both cognitive and physical exertion can really drain these people. And we use a lot of antidepressant medications and psychotropic medications that have a little bit of a stimulant effect and can also treat depression. Interestingly, as I said, fibromyalgia, chronic fatigue probably shares a lot of underlying similar causes or dysfunction. And so we are treating them similarly and have a specialist in this, Dr. Hackshaw at UTHA2, who is helping our clinic. Similarly, as I was saying, the neurocognitive dysfunction is quite real. It's related to their level of fatigue, isolation, depression, sleep deprivation. People's sleep cycle gets really disrupted from the virus. But most people do not perform poorly on formal cognitive testing. Once again, the fire alarms. And the major cognitive impairment like dementia is rare, and usually for people who are in the hospital. Although there was one study out of Britain that showed people had premature aging on MRIs, and actually it had an average loss of 7 IQ points after going through COVID. And so maybe it's not that their deficits are subtle, maybe it's just our testing is not good enough, but it's definitely real. People still having a lot of problems with smell and taste. 50% of patients during the initial illness can last to about a quarter of people afterwards. The prognosis for this is great. We think it doesn't actually damage the smell neurons themselves, it's the support structures, and those are regrowing over time, and especially once the chronic inflammation decreases. And so over 95% of people are recovering at 1 year. But if they're not and want to do it sooner, there's a cleverly named website, absent.org, which does smell retraining, which is almost mindfulness or physical therapy for the nose, getting strong sense, smelling them for about 20 minutes per day. And sometimes, most cases don't need it, but nasal steroids that can be bought over the counter for allergies can be effective too. Dr. Melamed, our neurologist, is going to talk about this, I think, in detail. But I think what is interestingly, and a lot of the patients who are coming to seek us have these weird chronic inflammation, dysautonomia, or mast cell symptoms, which are not really a diagnosis. They're umbrella terms to describe post-viral syndromes with these same effects. And basically, you can get POTS, postural orthostatic tachycardia syndrome, which is their blood pressures cannot be regulated by change in position, or people are describing new hives or allergies, environmental or food, which result in kind of wheezing, GI symptoms. And interestingly, the dysautonomia, the smallest fibers in the body control all the automatic functions of the nervous system that we just take for granted: gut motility, heart rate, tearing, sweating. And when that is disrupted from the virus, you can get all these different symptoms depending on what is disrupted. So I think I got a few more minutes. I'll go quickly. I think we screen everybody in clinic for mental health symptoms using standardized screening protocols. We have a licensed clinical social worker who's embedded in our clinic and really identifying their coping mechanisms, ruling out substance use, making sure people are sleeping fine and have their basic needs met on the Maslow hierarchy. And a lot of that's teaching skills of resilience through CBT and other evidence-based psychotherapy modalities. And some things with the pandemic itself. The social isolation makes this work, the grief, the loss, the guilt, financial hardship. It's complex to tease that out, which kind of takes me to the last point. I think, interestingly, as I said, these physical manifestations are absolutely real, but the illness itself, or the disease itself, the underlying microscopic function of patients is not always the illness, which is what is experienced by the patient. And I think this is a clever article or trial that was done, is they had people blow into a tube testing their lung function, and they gave them albuterol, which opens the airways, or other acupuncture sham treatment. And interestingly, when you looked at it, the albuterol opened the lungs and made them breathe better on the test. But when you asked them how they did, basically, if you did anything, all of these patients felt better. But if you did nothing, they noticed no difference. So even objectively, the breathing was improved only with the albuterol. With the rest of the treatments, they started to feel better, which is not to say that we are placebo doctors. Maybe that's 50% of our job. But part of this of giving the reassurance to the patient is giving them the resiliency to confront this disease, giving them the skills to feel better as they slowly recover over time, that their perception of the deficit is not always equal to the objective deficit that we can measure. And so helping them go through that and going along the path with them is really important to their overall getting better. You know, we need to understand their disease, but we also need to help them through their illness. So the last thing I think I always get questions about, I think it was widely publicized in the media that PASC symptoms changed after a vaccine. Unfortunately, it was a little bit too good to be true, but a little bit is true. So after getting one dose of the vaccine in this study, about 30% of patients actually felt like their symptoms of long COVID got better. Unfortunately, half of that, 15, 16%, felt worse, but most patients had no change in their symptoms after vaccination, and the rest on here got better before it even started. And so it's an interesting phenomenon. Does the vaccine retrain a dysregulated host immune response? Possibly in a small cohort of patients, but it is clearly not going to be effective for everyone. So this is our clinic. We published some clinical guidance and tried to write a lot of FAQs on there to get this word out. Part of our mission is educational because all providers are going to be seeing these patients and taking care of them. Like I said, 500,000 just in Texas as a small estimate. And so want to thank everyone, stay safe. I'm going to hand it over to Dr. Melamed.
Thank you very much, Dr. Brode. And I am going to go ahead and share my screen. Hopefully you can see my screen. Okay, wonderful. So thanks a lot. I'm very excited to talk about the evolving subject of post-acute sequelae of COVID-19, also known as PASC syndrome or long hauler syndrome. My name is Esther Melamed. I'm an assistant professor of neurology and neuroimmunology and director of research for the post-COVID program at Dell Medical School, together with Dr. Michael Brode. Very happy to be taking care of this patient population and learning as we go along about this syndrome. Here are my disclosures. My lab has received funding for COVID-19 research from the NIH, Austin Public Health, and Babson Diagnostics. And during today's talk, I'd like to focus on the pathophysiology of how SARS-CoV-2 affects the human body, then spend most of our time talking about the evolving knowledge about neurological complications post-COVID and their potential mechanisms. And then I will close with suggestions for prevention and recovery of this syndrome. So let's get started and talk briefly about how SARS-CoV-2 enters the human cells. And it does so through a receptor in our cells called the angiotensin converting enzyme 2 receptor, or ACE2. And it is the viral spike protein, and specifically the receptor binding domain of the spike protein, that allows the virus to bind to the ACE2 receptor on our cells and facilitate the cell entry. And SARS-CoV-2 is indeed a very smart virus. It has figured out a way to transform its host into a viral factory. And once it infects the cells, it directly goes to the host ribosomes and directs them to translate the viral RNA into polyprotein chains that then assemble into viral particles that bud off and enter the bloodstream. Of course, the host is not without its defenses, and antigen-presenting cells of the immune system are able to pick up the virus, break it down, and present it to other immune cells such as T cells and B cells, to then be able to mount an effective immune response to both attack the virus via T cell-mediated responses, as well as neutralize the virus via antibody production by B cells. As we have come to realize, as Dr. Brode described, the virus actually infects almost every organ in the body, including the brain. And the question is, why and how? Part of the answer is that ACE2 receptor is actually found across different body organs. And in the brain, it is found across different brain regions and in different cell types, including the microglia, neurons, oligodendrocytes, and blood vessels. The highest expression of ACE2 is in the pons and medulla and in the brainstem. So here I would like to transition to talk about the neurological complications of PASC. Indeed, neurological complications post-COVID appear to be some of the most common presenting symptoms in the PASC population, as Dr. Brode alluded to. And in the March 2021 study, a team from Northwestern looked at about 100 patients with COVID-19 symptoms. And in the study, they observed that neurological symptoms continued on until about 5 months. And 85% of patients in this cohort experienced ongoing neurological complications, whether they were positive or negative post-COVID. And in one of the largest epidemiological studies to look at PASC in a retrospective cohort of over 236,000 patients with COVID-19 and over 236,000 patients with the flu and other respiratory illnesses, researchers have found that neurological and psychiatric symptoms at 6 months were found in 33% of patients, and COVID-19 was associated with increased risk of neurological and psychiatric outcomes, but the incidence and hazard ratios of these were greater in patients who had required hospitalization, intensive care unit admission, or had developed encephalopathy. And this study found an increased risk of stroke, dementia, psychiatric disorders, substance use disorders in patients with PASC. But interestingly, Parkinsonism and Guillain-Barré syndrome were not statistically significant in this study for patients who had COVID-19 versus the flu or other respiratory conditions. Other studies are starting to demonstrate that women outnumber men in PASC symptoms overall, including in neurological complications. And women tend to have higher rates of these persistent symptoms, even though, as Dr. Brode mentioned, men seem to get the disease more severely during the acute stage of the disease. There are potentially 4 ways that the virus could get inside the nervous system. So one is that the virus could actually hitchhike into the brain through neurons. And we'll talk a little bit more about that in the next few slides. The virus could also get into the brain through the bloodstream. It could get into the brain potentially through the body's lymphatic system, or it could get in through a Trojan horse mechanism. And we will talk about each of these mechanisms briefly over in the next few slides. So how can SARS-CoV-2 reach the brain? And hitchhiking into the brain is something that other viruses have been known to do as well. For example, viruses like measles, rabies, and tetanus are able to get inside the brain by getting through the saliva. For example, with rabies, from a skin bite, the rabies virus travels along nerves to the spinal cord and then to the brain, where it multiplies. And from there, it can travel along nerves to the salivary glands and into the saliva to then proceed with the infection. And for SARS-CoV-2, because of the loss of smell, it's such a common symptom with COVID. One intriguing idea is that the virus might hitchhike into the brain through the olfactory nerve in the nose. And the evidence for this hypothesis is still being debated, but studies have shown that there are changes in the olfactory cortex, which is involved in our sense of smell, which suggests that there might be an effect through the olfactory nerve. But some studies also have shown that there are no ACE2 receptors in the olfactory cortex. And the question is, how could the virus get in? And there are other potential mechanisms. And one other mechanism could be through the vagus nerve, which is the longest and most complex of the cranial nerves and runs into the brain through the face and thorax and through the abdomen. And that may be another way that the virus could hitchhike and catch a ride into the nervous system. Now, another mechanism could be that the virus is getting into the nervous system through the blood-brain barrier. We can certainly detect the virus in the plasma of COVID patients. And when the lung tissue breaks down, where the virus commonly goes to after initial infection, the virus can escape into the bloodstream. And so the virus could potentially make its way into the brain through the bloodstream, through specialized endothelial cells on the blood-brain barrier. And we know that the brain and the spinal cord are immunoprivileged organs, but when there is infection, there's a lot of inflammation that leads to the break in the blood-brain barrier. And this break in the blood-brain barrier can allow both the virus and immune cells to get in. Another way could be through the lymphatic system. And this is a network of tissues and organs that is part of the immune system. And the lymphatic system has many functions, including maintaining body fluid levels, absorbing digestive tract fats, helping the body get rid of toxins and waste. And the lymph is a substance that's transported through the body and contains many infection-fighting white blood cells. And in the last couple of years, we have learned that the brain also has lymphatic vessels around the dura. And this is the lymphatic system would be another potential way that the virus could get inside the nervous system. Now, the last way that we'll briefly touch on is a Trojan horse entry. And this is a mechanism that has been suggested to allow SARS-CoV-2 to infect different types of blood cells like macrophages and lymphocytes and get into the brain and spinal cord compartment by hiding inside these white blood cells. This mechanism has been seen with other viruses like HIV, which lives inside monocytes and can get inside the brain without lysing the monocytes until it's at the location. So how can the virus then damage the nervous system once it is in the body or once it gets inside the nervous system? So there are also potentially 4 ways that have been proposed. One is direct brain invasion or spinal cord invasion, as we've been hypothesizing. The other one could be a dysregulated immune system that occurs after the virus has infected the individual, and we'll talk a lot more about this mechanism next. We also know that blood clots form in patients who have COVID, and that could be another way that brain and spinal cord could be damaged. And if people are sick enough, they may experience low oxygen, which can damage the brain because the brain needs a lot of oxygen to function. So there have been several cases now that we have seen in clinic and that have been documented in the literature of central nervous system demyelination. And that is a process through which the brain and spinal cord are damaged, and people can develop different types of neurological symptoms that involve the motor and the sensory systems, as well as bowel and bladder symptoms develop depending on where the demyelination happens. And these conditions can be as varied as multiple sclerosis, transverse myelitis, acute demyelinated encephalomyelopathy, or neuromyelitis optica. And one thought is that this type of demyelination due to inflammation may be happening because of a process called molecular mimicry, whereby the virus is taken care of by the immune system, but later on the immune system stays dysregulated, and other proteins in the body, for example, such as myelin, may look like a piece of the virus, and then the immune system will go after those cells that have the protein that looks like the virus itself. Now, another system that has been dysregulated in patients with post-acute sequelae of COVID-19 is the autonomic nervous system. And Dr. Brode alluded to dysautonomias in patients. And these patients suffer from multiple organ dysfunction. And that's because the 3 arms of the autonomic nervous system, the sympathetic, parasympathetic, and enteric systems, all are controlled by the brainstem circuits. And different bodily functions could be altered when the brainstem is not functioning properly, such as cardiac, respiratory, GI, and endocrine systems can all become dysregulated. And patients with dysautonomias may be presenting with all of these different symptoms, and it may be difficult to diagnose if suspicion is not high enough for this possibility. Now, how can the autonomic nervous system dysfunction arise? Well, some of the thoughts are that there may be immune dysregulation with generation of autoantibodies. It may be that there is dysregulation with herpetic virus reactivation that has been brought up as one possibility. It could be that these patients are deficient in vitamin D, which is an immune modulator. And it is also possible that there is direct damage to the brainstem, which controls all the autonomic functions in the body. Now, there have been several reports demonstrating that antibodies in patients post-COVID are abnormal. So they are autoantibodies really to different proteins and significantly to neuronal proteins, such as NMDA receptor, myelin, gangliosides. And we're trying to understand whether these autoantibodies are transient when we detect them in patients, or whether they will stick around for a long time and contribute to an increase in autoimmune diseases in people who have been affected by COVID. This is another study that has showed tissue-associated autoantibodies that are related to immune genes, including interferon antibodies, and other immune genes. This group also identified antibodies to coagulation factors, antibodies to vascular cells, connective tissue extracellular matrix components, and different organs. And very interestingly, 10 of the patients in this study had antibodies to HCR-TR2, which is an orexin receptor that is enriched in hypothalamus and may be relating to a lot of the sleep abnormalities that we see in patients post-COVID. Now, specific immune cells have also been shown to be increased in patients with PASC. In this small study of 20 patients, with ongoing symptoms and 30 patients with resolved symptoms, researchers found that T follicular helper cells were increased, as was the number of immunoglobulins, IgG immunoglobulins to the spike protein of SARS-CoV-2. T follicular helper cells are interesting because they play an essential role in germinal centers, which are structures where B cells differentiate into plasma cells and proliferate and start forming antibodies. And these T cells help to activate the B cells. It's not clear right now what does this finding mean, but research is ongoing to understand better, and it is possible that this might be one of the answers to the rise of autoimmunity potentially if there is dysregulated regulation and interactions between T cells and B cells in these patients. One mechanism that has been brought up as a potential way that SARS-CoV-2 could act as a nidus of autoimmunity is herpetic virus reactivation, such as EBV and HSV. And viruses like EBV have been linked to different immunodeficiencies, including multiple sclerosis and other autoimmune diseases, as well as different types of cancers like lymphoma, Hodgkin disease, and as well as to chronic fatigue syndrome. In EBV, and HSV, well, EBV specifically tends to stay dormant in immune cells like B cells, but also can infect T cells and natural killer cells, and can become reactivated during times of stress, infection, or burns. And while this reactivation does not necessarily cause an acute disease, the thought is that the reactivation could trigger the type of immune response, which could potentially cause damage to nearby tissues, as well as cause latent autoimmunity, and has been hypothesized for the case in multiple sclerosis, where most patients are EBV positive at the time of their diagnosis. Again, this is currently a hypothesis that has not yet been evaluated fully, but is interesting to suspect that SARS-CoV-2 not only causes damage by itself, but could bring other viruses to the table. Now, it is still not known whether it will be reactivation or not that explains post-COVID symptoms. And it may be that there is a very heterogeneous picture in that some patients might have dysautonomia as a result post-COVID. Other patients may have long-standing systemic inflammation. Other patients may have specific inflammation as a result of reactivation of herpetic viruses, and yet other patients may have neuroendocrine activation. But in this study looking at EBV reactivation, they found that of 30% of patients out of 185 randomly surveyed patients, about 30% patients had post-COVID symptoms, and about 66% of these patients had reactivation of EBV by serological markers compared to controls. And I briefly mentioned neuroendocrine activation on the last slide, and I just wanted to bring it into focus that COVID and SARS-CoV-2 really affect multiple endocrine glands in the body, including the hypothalamus, pineal gland, pituitary, adrenal glands, ovaries and testes, pancreas, thymus, and thyroid. And by doing so, can contribute to neurological symptoms because all of these endocrine organs work closely with the brain and spinal cord. And with that, I'd like to briefly touch on PASC prevention and recovery. Now, prevention is really key to avoid this long haul syndrome. And factors that are important for brain health are keeping the brain energized with a healthy diet and vitamins. Vitamin D has been shown to be beneficial in a lot of autoimmune diseases, but also in COVID-19 as an important immunomodulator and neuromodulator. Exercise can help to keep the brain cells active and getting oxygen, and that's why we recommend to patients to start a gentle exercise program in order to help recover. Sleep is so important for regeneration of the brain, and a lot of patients have difficulty with sleep post-COVID, and so that's one of the very important areas to work on closely. And engaging in activities to reduce stress, such as meditation and doing other things that people enjoy in order to reduce stress. And of course, with a booster that is now available for COVID-19 for specific groups of people, it's very important to keep the immune protection up to avoid getting COVID-19, as there have been breakthroughs even in people who have been vaccinated previously, and to prevent the transition to PASC. And with that, I will close in saying that the scientific road to defeating the virus and PASC is really going to be long, and it is not straightforward, but rather convoluted and complex, even with effective vaccines that work and that are safe. And it's really going to involve a lot of different people, including physicians and scientists, patients, legislators, and funders, to crack the code of the virus and to learn how to prevent and treat COVID-19's acute and chronic complications. I'd like to close and acknowledge a lot of people that have been working hard over the past year with getting the PASC clinic up and going. And I want to specifically thank Dr. Michael Brode and Dr. Lucy Lycombe, our executive, Dr. Michael Brode, the medical director of the PASC program, and Dr. Lucy Lycombe, the executive associate chair of the Department of Internal Medicine, for their ongoing vision and tremendous support of the PASC program. I would also like to extend a big thank you to the chair of the Department of Neurology, Dr. David Pedafar, Associate Chair for Clinical Integration and Operations of the Department of Neurology, Dr. Steve Roach, Associate Chair of Research of the Neurology Department and Assistant Dean of Faculty Affairs, Dr. Bill Schwartz, Vice Dean of Research, Dr. Steve Strakowski, Executive Clinical Director, Lisa Jackson, Chief Clinical Officer of UTHA, Dr. Amy Young, for all of their ongoing support of COVID-19 research and clinical operations. And I would also like to thank the UTHA Neuroimmunology Clinic staff who have helped to get me started in seeing patients with neurological post-COVID symptoms in the last year. Here, Leah Reedlon, Sarah Walter, Harlan Johnson, and Keitha Dendy. And also would like to thank staff at the UTHA Post-COVID-19 program for their help with getting the clinic started and running successfully. Kelly Sorensen, Sarah Burson, Aaron Braverman, Henry Guevara, Jeffrey Sanyam, as well as my colleagues at the Austin PASC Collaborative for very exciting and interesting discussions in education on COVID-19 and PASC. And I would also like to thank all of the scientists and clinician scientists, and students who have been involved in our lab's research.